Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's the latest with gastrointestinal endoscopy, disease assessment, and management? Find out more right now. My guest this evening is Dr. Samir Charbel of the MedStar Medical Group. Samir, welcome to Housecall.
Thank you. Thank you for having me.
So briefly tell our viewers about your role with MedStar and your professional background.
Sure. Thank you for having me, Dave. Good evening, everyone. So my name is Samir Charbel, and I joined MedStar Gastroenterology 2 years ago as a site director here at MedStar Montgomery Medical Center. I practice between MedStar Montgomery Medical Center, Silver Spring, and the Washington Hospital Center, where I do general gastroenterology, but also advanced endoscopy with the main focus on biliary endoscopy. So as far as background, I grew up in Lebanon. I went to medical school in Beirut, Lebanon. I moved to the US about 20 years ago, where I finished my internal medicine residency at the Cleveland Clinic in Ohio. And after finishing internal medicine residency in Cleveland, I moved down to North Carolina, where I trained in gastroenterology and advanced biliary endoscopy. I graduated in 2009 and have been practicing basically for the past 14, 15 years. I practice general gastroenterology and advanced endoscopy.
Very nice, very nice. So tell us about the sweep, the development of our discipline, gastroenterology, over the years. How has it evolved from your perspective?
Absolutely. So this is a great question. It's actually fascinating to me to see how things have changed over the past several decades. As you know, Dave, gastroenterology, when it first started as a specialty, about 60, 70 years ago, it started initially as more like a suit and tie type of profession, where the gastroenterologists were mainly providing advice and trying to rely a lot on very basic diagnostic tools, relying a lot on the physical exam, stool studies, some basic imaging modalities to provide diagnosis and advice. And a lot of time, the advice was not solid, was not based on solid evidence-based medicine. So over the years, things have changed. And I think one of the main breakthrough in the history of gastroenterology was the addition of flexible endoscopy in the mid of the last century, as that started initially as a diagnostic tool that would allow us to look at the stomach, the colon, and get some diagnostic information. Then later on in the 60s and late 70s, endoscopy has shifted from not only being a diagnostic tool to, and it started having a therapeutic role. So endoscopists and gastroenterologists started being able to provide therapeutic interventions and not only diagnostic information.
Let's go on then to discuss what sort of diseases in 2024 can be diagnosed with gastrointestinal endoscopy.
So gastrointestinal endoscopy diagnoses a large variety of gastrointestinal diseases. I would give some of the most common examples. For example, we can look at the stomach and the small bowel, the esophagus, and diagnose peptic ulcer disease, gastritis. We diagnose with endoscopy gastrointestinal cancers in different locations. We also, for example, diagnose inflammatory bowel disease like Crohn's disease, ulcerative colitis, as well as colon polyps, strictures along the way of the GI tract can also be diagnosed with endoscopy. These are just some of the examples.
Let's go on then to a specific type of advanced endoscopy, one that you're trained to do. ERCP, what does that stand for?
So ERCP stands for endoscopic retrograde cholangiopancreatography. I know it's a fancy name for, basically it's a procedure It's an endoscopy procedure that combines endoscopy and fluoroscopy. So it combines endoscopy and imaging. So the endoscopist, after inserting a scope with a light through the mouth of the patient, will have two monitors, will be able to see on a video monitor what images we're obtaining from the camera built into the tip of the scope. And then we'll have another monitor, which is an X-ray monitor, where we can see what kind of imaging we're obtaining after injecting contrast in the bile duct and the pancreatic duct and then the liver, etc.
So what are the main indications? What are the reasons to do an ERCP?
So the main indications for this procedure are gallstones, for example, stones that can get stuck in the bile duct or the pancreatic duct. Usually those stones pass from the gallbladder. Patients may or may not know that they have stones in the gallbladder, and sometimes they present with a stone that's stuck in the main pipe of the liver. That's one of the common indications, probably one of the most common indications. Another indication, for example, patients can have a narrowing or blockage on the bile duct or the pancreatic duct that can be either benign or malignant. This is where the patients will be usually, after having some cross-sectional imaging like ultrasound, CT scan, MRI, this is when the patient is sent to us for this type of procedure.
So let's drill a little deeper on your reply there. So if somebody has a stone in the common bile duct, the tube that drains the liver into the intestine, what can you do by way of treatment through the scope to spare the patient an operation?
Sure. So after we advance the scope all the way to the small intestine, to the area where the bile duct empties in the small bowel, we advance a catheter through the channel of the scope, and we inject contrast in the bile duct to see where the stone is exactly and how big the stone is. Then we can do what we call a sphincterotomy. We can cut the sphincter of the bile duct, and everything will be done through the scope. There's no incision. And after we widen the opening of the bile duct, we can advance different devices inside the bile duct, also through the channel of the scope. We can advance balloons or baskets or other type of equipment to pull the stone all the way down from the bile duct to the small bowel, where it will eventually pass by itself in the stools.
Do you ever run into a really big stone that may not pass? What can you do with a really big stone?
Definitely, definitely. Every now and then we come across stones that are larger than usual, and we have a wide variety of different options that we can do. One of them, for example, is we can do what we call a lithotripsy, and there are different techniques to do it. One of the most commonly used techniques is what we call mechanical lithotripsy, meaning that we advance a basket. Once the stone is inside the basket, we can't crush the stone. We have the devices that can crush the stones and bring them down in pieces. That's one of the options. Another option, if the stone is too big and we cannot remove it at the time of the procedure, we can put a stent across the stone, basically bridging the area where the stone is causing the obstruction to allow for the flow of the bile. And in this case, the patient will need another procedure, but that's an exceptional scenario for very large stones. Most of the time, we can remove the stone during the first ERCP.
What about if you find a cancer in the pancreas that's causing a stricture, a scar, that leads to drainage issues in that area? What can you do?
That's unfortunately also a common scenario as pancreatic cancer is becoming more common, unfortunately. So in this setting, what we can do, we can brush the area of the narrowing to send some tissue to the lab to be tested to confirm the diagnosis. But one of the most common procedures we do in this setting is we place a stent. A stent is like a tube that can be either plastic or metal that can bridge the area of the obstruction and allow for the bile to drain through the stent and bypassing the area where the pancreatic cancer is pushing on the bile duct and hindering the flow of bile.
We're going to shift gears now to an entirely different important topic, and that's colon polyps. Explain briefly for our viewers what exactly is a colon polyp and what is its significance?
So polyps are a growth that start at the lining of the colon. Some of those polyps have the potential to turn into cancer over time. That's what we call precancerous polyps or pre-malignant polyps. The other medical name for those is adenomas. They can turn into cancer over a period of time. So this is what polyps refer to, and they can have different sizes, different types.
I think one of the interesting developments in our discipline's approach to polyps has been its evolution. For many years, a smaller polyp was viewed as the purpose of colonoscopy to remove, and larger growths, if they were benign, we often sent to surgeons to have it removed, perhaps laparoscopically. What has been the change there over the last few years? What are some of the new techniques that you can do to remove large growths and once again spare the patient from going on to the OR?
Sure, yeah. So this is an area that evolved significantly over the past 15, 20 years. Like you mentioned, Dave, in the past, any large polyp used to need an open surgery or laparoscopic surgery. Now we have techniques like endoscopic mucosal resection or endoscopic submucosal dissection or some other techniques that we do through the scope that would allow us to handle even large precancerous polyps. What we do, we inject a substance through the scope between the polyp and the different other layers of the colon or any area of the intestine or the stomach, and this will create a certain cushion between the polyp and the rest of the mucosal layers, and then we resect the polyp sometimes in one session, sometimes piecemeal, one session after the other. And that will allow us to handle and remove a large polyps. And then at the end of the procedure, we have devices we can put to close the mucosal defects, like clips that we can apply to bring the healthy mucosa from each side of the polyp closer to each other. And that will decrease the risk of bleeding and perforation.
We're going to pause briefly for a public service announcement. More with my guest, Dr. Charbel of the MedStar Medical Group. We'll be right back.
Life doesn't always give you time to change the outcome. Prediabetes does. One in 3 adults has prediabetes, and you could be one of them. There are usually no signs for prediabetes, so it's important to understand your risk. With early diagnosis, prediabetes can be reversed, and you can change the outcome. Take the 1-minute prediabetes risk test today. Go to doihaveprediabetes.org.
We're back, and my guest is Dr. Charbel of the MedStar Medical Group. And the topic this evening is the latest in gastrointestinal endoscopy. Dr. Charbel, when we paused for the public service announcement, you were discussing elegant techniques to remove large benign growths from the colon. At this point, is there ever a time where we still need to send large benign growths to the surgeon, or can you handle the large majority of these growths?
So a great question. With the new techniques that we have, I would say we can handle over 90% of large polyps. Now, every now and then, if the polyp is bigger than a certain size, or if it's in a certain location of the colon where the wall of the colon is very thin, we always discuss with the patient the risks and benefits of the procedure. And if we feel that removing these type of polyps carries a significant risk of complications, then we discuss this with the patient, and we recommend sending the patient to the surgeon. It all depends on the size, the location, and how we feel about the polyp, if we feel that this is something that we can remove safely endoscopically or not. But as I mentioned, with the new techniques, the spectrum has shifted, and there's a lot more polyps that we can handle endoscopically. And I would say sometimes we go for 6 months to a year without needing to send a large polyp to a surgeon.
And what would you say is the main advantages and the main risk of doing this advanced technique, endoscopic mucosal resection?
Sure. So the advantage of it is that it is done at the time of colonoscopy. The patient will need to be sedated the same way as they're sedated for colonoscopy. It is IV sedation, does not require general anesthesia. There's no incision. Everything is done through the channel of the scope. So these are big advantages, and sparing the patient the mortality and morbidity of a surgery. The complications, the two most common complications are bleeding and perforation. But as I mentioned, we have techniques, we have things we can do at the time or at the end of the procedure to decrease this risk, like closing the mucosal defects with different devices like clips. And of course, for patients who are on blood thinners, they'll have to hold their blood thinners for a certain time to decrease the risk of bleeding.
And once again, these are outpatient procedures. Patients go home after the procedure. Is that correct?
Absolutely, absolutely. They're outpatient procedures. They may take a little longer than a regular colonoscopy. Like an average colonoscopy can be 20 minutes to 25 minutes. Sometimes those procedures can take up to an hour, sometimes a little over an hour, but most of the time they're around that time, and the patient will go home immediately after being watched or observed for half an hour, 45 minutes after the procedure.
What an interesting evolution of our discipline.
Absolutely, absolutely. It's fascinating to see how things have moved over over the past years, and one would wonder, where are we heading? What's next?
Absolutely, it makes it so interesting. Let's go on to shift to another very important topic, which is gastrointestinal bleeding. Really share with our viewers the different causes of bleeding from the upper GI tract, and then also the causes of lower GI bleeding. And then we'll go on to some of your exciting treatment options.
Sure. So when it comes to bleeding from the upper GI tract, the most common etiologies or causes are peptic ulcer disease, for example, ulcerations in the stomach or the small bowel that could be related to either taking a lot of NSAIDs, medications like ibuprofen, etc., or could be related to a bacteria in the stomach that we call H. pylori, for example. In patients with liver disease, you could have varices or enlarged veins in the esophagus or the stomach that can burst and bleed. Other causes are, for example, you can have what we call arteriovenous malformations. You can have small vessels that can get too close to the lining of the stomach and erode and bleed. When it comes to the upper GI tract, I would say those are the most common causes of bleeding.
So how would you approach some of the causes you just outlined? Let's start off with a bleeding ulcer. How do you treat a bleeding ulcer?
So it depends on how the ulcer looks and if there's a vessel in it or not. But one of the devices or one of the techniques we use is deploying clips. We have metal clips that we can put on the ulcers. And right now we have larger and larger clips. We even have clips that can be advanced through the scope or over the scopes. We now have clips that we deploy over the scopes. They're large clips, and we can grab a lot of healthy mucosa from one side to the other of the ulcers to close the area that's bleeding. We also have injections. We inject certain substances to shrink the vessels and decrease the risk of bleeding. And we can also cauterize. We can advance certain equipment and devices through the scope that would allow us to burn and cauterize the areas bleeding, the vessels that we see that are bleeding. And this way we control the bleeding and the setting of bleeding ulcers in the vast majority of the cases.
So you have many options available. One of the exciting new developments, as you know, was originally developed on battlefields used by the military, called hemostat spray. Share with our viewers what that is all about.
So hemospray is a powder that is made of certain minerals that has the capacity to bind to the bleeding area. So basically, it's a powder that we inject, we spray through the scope with a catheter, and this powder will bind to the area that is bleeding and will create like a gel. So it will basically prevent further bleeding by creating a layer over the bleeding area. And this is very exciting because we use it as a lot of time as a last resort when the other first techniques that I mentioned don't work. We can spray this area, and it's fascinating to see how, you know, when we're looking at a lot of bleeding, all of a sudden after we spray this substance, it binds to the bleeding area and stops the bleeding immediately.
Do you use these techniques in combination?
So yes, absolutely, absolutely. We use them in combination. We always start with the most simple and conventional methods that I mentioned, like injections, clipping, cauterization. If we feel that we need additional push from something else, we use the technique that I just mentioned. But there is data, for example, with a lot of studies showing that two techniques in the setting of bleeding ulcers, for example, is certainly better than one. So we use them in combination on a regular basis, absolutely.
You mentioned earlier varices, swollen veins secondary to advanced liver disease, liver cirrhosis. So what do you do when somebody bleeds from these swollen veins in the esophagus?
Sure. So for those varices, we have a technique called endoscopic band ligation, where we apply a device on the tip of the scope that would allow us to suction those big varices and apply rubber bands on them. Those rubber bands will help those varices shrink, and when the blood supply doesn't get to them, they fall on their own. So we can eradicate, or use the term ablation, we can ablate or obliterate those varices by doing those techniques, endoscopic band ligation. This has really affected the management of varices significantly. And you know, this in the past, when somebody would vomit or would bleed from varices in the setting of liver disease, the mortality was extremely high. Now with this technique, we can allow them to get their bleeding under control and treat their liver disease and give them basically another big chance to survive and improve after that.
Ironically, this technique is quite similar to what is used to treat hemorrhoids as well.
Exactly.
Yeah.
Exactly.
So let's go on then to discuss the lower GI bleeders. What are some of the causes there?
So lower GI bleeding, one of the most common reasons is hemorrhoids, like you mentioned. You can see blood in the stools from hemorrhoids. But for people who bleed more than just a little bit on tissue paper, diverticular bleeding, diverticulosis is one of the most common causes. Diverticulosis are small pockets that are very common. Most people who have them will never have problems, but every now and then, a small vessel at the neck of those pockets can bleed. And this is, you know, one of the causes of bleeding. But of course, another cause of bleeding from the lower GI tract is cancer. Colon cancer is another possibility.
And what are some other causes of bleeding besides that?
Some other causes of bleeding, you can have inflammation of the colon, like colitis, that can have a different etiologies. Different causes can cause inflammation and ulceration in the wall of the colon, like ischemic colitis, for example, where the blood supply doesn't get well to the lining of the colon. Or you can have Crohn's disease, ulcerative colitis, also arteriovenous malformation, small blood vessels, and the colon can erode and bleed.
Finally, we're going to briefly cover another important topic, esophageal strictures. What exactly is esophageal strictures?
So esophageal strictures are narrowing in the lining of the esophagus. Usually, they can be benign or malignant or cancerous. Luckily, most esophageal strictures are benign, and they're usually related to chronic reflux. This is the most common cause of esophageal stricture, is people who have reflux for a long time, reflux can lead to building scar tissue in the esophagus that can narrow the lumen of the esophagus and cause trouble swallowing.
We have 1 minute. What are your treatment options for that narrowing? 1 minute.
So what we can do, there are different treatment options. The most commonly used treatment option for benign esophageal stricture is what we call endoscopic dilation. And the way we do that is through the scope, we advance a catheter that has a balloon at the tip of the catheter. And once we see where exactly the stricture is, we advance the balloon proximal distal to the stricture, and then we inflate the balloon. We keep the balloon inflated for a certain period of time, and then we can see what's happening to the stricture. The advantage of it compared to the old techniques where people used to have like bougie dilators and stuff like that, the advantage is we can see at the time of the dilation what kind of impact we're doing to that stricture, and we can decide then if we need to go higher on the diameter of the balloon or not.
Very good. Samir, thank you so much for a very informative interview. If our viewers have any questions, how can they reach you?
Thanks very much for having me, Dave. So viewers can reach me on the website, medstarhealth.org. Our office informations are available there. I see patients both at MedStar Montgomery Medical Center in Olney and in Silver Spring. And the information are available on medstarhealth.org. Thank you very much.
Thank you for a very informative interview. My thanks to Dr. Charbel for this evening's fascinating information. My thanks to my team at the station for putting this program together. And my thanks to you, the viewer, for joining us this evening. We do look forward to seeing you next time on another edition of Housecall. Good evening.